Hello everyone, I am François Lignereux, an ophthalmologist at the Sourdille Atlantique Clinic, specializing in retinal vitreous surgery and in cataract surgery for 25 years. The number of cataract surgeries increases every year, while the number of surgeons tends to decrease. In this context, optimizing operating time has become a major challenge, both in terms of flow and costs. HFLACS, femtosecond laser-assisted cataract surgery, improves surgical precision, but often extends the total procedure time. In this video, I used a new handheld femtosecond laser, the RX laser from Helix Surgical, and I compare my workflow with HFLACS and standard manual techniques. I have called this new technology HFLACS for handheld FLACS. For this comparison, I have arranged for a standard setup, a single operating room, a medical team to assist me. In this analysis, the laser time is included in the preoperative phase, and it is crucial to highlight that certain preparation steps take place concurrently with the end of the previous patient's surgery, thus optimizing the sequence of surgeries. In order to compare the various surgical workflows, 3 separate timelines are shown during the video, each illustrating a specific technique. Manual technique is shown in green, HFLACS in blue, and FLACS in purple. The steps specific to the laser, whether HFLACS or FLACS, will be highlighted in gray. You will find these simplified timelines at the bottom of the screen. With the HFLACS, I decided to perform the capsulotomy directly in the induction room. Regardless of the type of procedure, certain steps in the protocol remain constant. My team applies antibiotic, anesthetic, and mydriatic drops to the patient, then prepares the operating room for the next procedure. During this phase, I am not needed. I take advantage of the time while my team is setting up the previous patient in the operating room to perform the laser capsulotomy on the next patient after applying an anesthetic drop. The mobility of the battery-powered system allows me to easily position the laser near the patient. The absence of suction and settings allows me to place the interface directly on the eye, unlock the laser safety, grasp the handpiece and position the device while adjusting the centering. The laser shot, which lasts only 4 seconds, can then be triggered. In less than a minute, the capsulotomy is completed, and I can return to the operating room where the previous patient has already been set up. This organization optimizes my time, avoids an additional step in the operating room, making the transition smooth and perfectly integrated into the standard workflow. At the end of this initial preoperative phase, differences are already observed depending on the techniques used. The average preoperative time for the manual method is about 30 minutes. During this phase, it is mainly my teams that are engaged. With the HFLACS, the preoperative time remains similar to that of the manual method. However, with FLACS, the preoperative time is longer and can reach 39 minutes. The increase in time is explained by several additional steps. The patient is moved to the laser, where data is entered and settings are adjusted, followed by positioning and suction, image acquisition, laser treatment, and the capsulotomy procedure, pre-fragmentation of the lens, and corneal pre-incision. Then, transfer of the patient to the operating room. These steps add a significant amount of time before the actual surgery. Let's move on to surgery. When I start my work in the OR, the capsulotomy has already been performed. I can therefore directly remove the rhexis using either a rhexis forceps or a cystotom. Another option is to aspirate the capsular disc with the phacoemulsifier. This step is quick and smooth, and the centered circular and well-regularized opening facilitates the rest of the procedure. This procedure would be identical if the patient had undergone a FLACS. According to the literature, the average time required to perform a manual rhexis varies between 30 seconds and 1 minute 20, depending on the surgeon's experience. Once the capsulotomy is done, regardless of the method used, HFLACS or manual, the rest of the procedure follows a comparable protocol. First, hydrodissection is performed, ensuring it is done well under the anterior capsule, as the masses are cut cleanly at the edges of the rhexis during a femtosecond capsulotomy. Then, phacoemulsification. Where the FLACS stands out is in the pre-fragmentation of the lens, which reduces the time and energy needed for phacoemulsification. Conversely, they require the patient to be transferred to a laser, and a calibration time, which lengthens the process. In practice, the combined time of the laser and surgery often reaches 15 to 20 minutes. In comparison, the manual technique has the advantage of a continuous surgical flow without interruption. However, the quality of the capsular hexis entirely depends on the surgeon's skill. With the HFLACS, since the capsulotomy is performed in the induction room, the procedure can continue without any break in flow. Once the rhexis is extracted, phacoemulsification can immediately begin, allowing for an operative time of 10 to 15 minutes, very comparable to the manual method, but with the added precision of the laser. In femtosecond technique, I strongly recommend adopting a bimanual approach, especially during the aspiration of the masses, to avoid the risk of excessive pulling on the rhexis. Once the lens is removed, I carefully clean the remaining cortical masses, then insert the implant and position it in the bag. All these steps proceed similarly whether the capsulotomy was performed with an HFLACS, a FLACS, or manually. However, the advantage of the femtosecond laser lies in the increased precision of the rhexis, which helps the centering and stability of the implant. Let us examine how the various techniques stack up regarding their operational duration after the preoperative phase has concluded. The manual method takes about 10 to 15 minutes on average, which leads to a total time of 40 to 45 minutes. With an HFLACS, the duration of the procedure remains very close to that of the manual, or perhaps slightly reduced, as the rhexis is already performed beforehand. Thus, a similar total duration is achieved between 40 and 45 minutes. Considering just the operative time, FLACS methods save about a minute compared to manual techniques. With the HFLACS, the preoperative time remains similar to that of the manual method. In contrast, with the FLACS, the preoperative time is longer and can reach 39 minutes. The integration of femtosecond lasers into the surgical workflow is a key issue. The FLACS improves certain technical steps, but at the cost of a longer total operative time. Conversely, the HFLACS offers an effective compromise by combining laser precision with an optimized workflow. An important point to highlight is the cost. The FEMCAT study concluded that the FLACS was not cost-effective due to its high expense. However, with the HFLACS, we now have a cheaper solution that allows us to enjoy the benefits of the laser without compromising the economic viability of surgical centers. Innovation should not only enhance our surgical techniques, but it must also be accessible and efficient. In this regards, the HFLACS represents a major evolution. Thank you for your attention.